is Beth Mole and I'm Secretary of the Queensland Nurses and Midwives Union. Welcome to the third of our Toolkit talks, and it's going to be a fantastic presentation tonight by Professor Mary Chiarella from the School of Nursing and Midwifery at Sydney University. Mary is a world-renowned nurse leader and researcher who has a distinguished career in nursing services. And we were just having a lovely chat before this presentation on the fantastic research that Mary's about to have published. It's very exciting, her body of work, and it's been going for very, very many years. But today, Mary's going to be talking to us about collegial generosity, a very, very important topic for our professions of nursing and midwifery. After Mary has spoken, there'll be an opportunity for you to ask questions. To ask a question, all you have to do is type in the question into your keyboard, and we have a moderator here, and I'll be able to ask the questions on your behalf. Similarly, if you have an issue, all you have to do is type it into the right-hand tab of the screen. So it's all, the instructions should have been sent to you prior to the webinar starting. So I'd like to now hand over to Professor Mary Chiarella, who's going to provide the presentation for tonight. And Mary's come all the way from Sydney, so we'd like to thank her very much for making the trip up here. She's a very long-standing and fantastic friend of the QNMU, and it's wonderful to have her here tonight. Thank you, Mary.
Thank you, Beth. Hi, thank you so much for having me, and I'm very pleased to talk to you on collegial generosity. This is the third time that Beth has asked me to come and talk to you about collegial generosity. And the first time that I came was actually to explain a study that we've done in relation to models of care. And then the second time I came to talk about it, I decided to talk about the politics of collegial generosity and actually the collective nature of collegial generosity. And tonight, because of some developments nationally in relation to the Nursing and Midwifery Board, I'm actually going to talk about collegial generosity as our individual role. So just to let you know what I'm going to talk about, I'm going to briefly mention the concept of collegial generosity and just the origins of the phrase in relation to the work we did in models of care, just for those of you who weren't here at the first or the second talk on this I did. I then want to talk about the Nursing Midwifery Board of Australia Registered Nurse Standards for Practice and Collegial Generosity, and just to explore the criteria that they've set up for collegial generosity. And as I say, today I want to focus on the individual in relation to collegial generosity and just think about how we enable ourselves to meet these criteria. And the things that I want to talk about are resilience, mindfulness, exercise, and kindness. So these are just some definitions of collegial generosity. Collegial basically means of, relating to, or ruled by colleagues. And the Roman Catholic Church has its own definition, which is that it's ruled by bishops having equal power, possessing adherence to the ethos, standards, and conduct that govern behavior among colleagues within a given organization or profession. And clearly that would be the concept of collegial that I would be talking about and thinking about. This notion that we actually share an ethos, that we share standards, and that we share conduct. Generosity, well, readiness or liberality in giving, nobility of thought or behavior or magnanimity, and freedom from meanness or smallness of mind or character, all of which I think we'd all like to think that was pretty much us, really. So why do such ideas matter? Because we know from about 30 years of research on motivation in nursing that we do share common value sets, and therefore there is more that unites us as a profession than divides us. And some of the work that we did into models of care demonstrated that innovation and teamwork only occurred when there was an ethos of collegial generosity. And obviously we can achieve so much more when we work together than if we fight each other. And we know, and this was what I talked about last time, that governments will be more inclined to listen to voices speaking in unity. And they're able to ignore dissonant voices on the grounds that in favouring one, they might upset another one. So when we were doing the initial research into models of care, when I coined this phrase collegial generosity, we found that clinical skills and measurement and audit skills were critical to be able to implement program changes. Good decisions are always based on good data. But what was really interesting to us as we were looking at these really successful change management programs in the models of care were these recurrent narratives of both unsuccessful and successful models. And the themes kept being repeated. They were repeated whether it was a small rural site or a major teaching hospital. It was the same story. And what we found was that there was this ethos of collegial generosity as the ideal, but there were two ends of a dysfunctional spectrum. And one was a story of accountability, either too much accountability, and at the other end, too little. What worked was this fine balance of mutual trust and respect, a recognition of the fact that everyone had responsibility and that they were all supported by each other. And so what I did at the time was I put together this environmental overview. So at one end of the spectrum, there was what we call the ethos of collective non-responsibility. So people would go, well, you know, I told somebody about this. And what did they do? Nothing. And it was like that was the end of the story. So what we said was that set up in practice a zone of abrogation where once you told somebody else, it was no longer your responsibility. It wasn't anybody's responsibility after that because you told someone else there was a problem. At the other end of that spectrum, and equally as scary, or maybe even scarier, was this notion that there was this, look, the only person who does anything around here is me. If I don't do it, it doesn't happen. And so there was this kind of ethos of individual accountability, which set up in those people this sort of sense of bitterness, of isolation, of alienation. People felt that they were the only person in the organization who was actually responsible for the challenge. Neither of those worked, you'll be amazed to know. The first one didn't work because nothing happened, and the second one didn't work because if that person fell over, then nothing happened. So what we found did work was where there was this zone of mutual trust and collaboration. And that was when I coined this phrase of collegial generosity. The people worked together, that they shared the same values, they shared the same ethos, but they were prepared to say, look, you know, we don't think this is working. And because they trusted each other, they were prepared to explore new ideas. And so you can imagine my delight when I found the phrase in the registered nurse standards. So it says, standard 2 in the new RN standards, which were published last year, that the RN engages in therapeutic and professional relationships, and that registered nurse practice is based on purposefully engaging in effective therapeutic and professional relationships. This includes collegial generosity in the context of mutual trust and respect in professional relationships. So I was delighted that this had moved forward and that actually it had been taken up through the consultations that the researchers for the RN standards had done with the profession. And what they'd identified was this number of criteria that served to provide examples of the types of activities required under the standard. The criteria are not exhaustive, but they are intended to be indicative. So I'm just going to run you through them because I'm then going to cherry pick them a bit. So the first standard 2.1 was that the registered nurse establishes, sustains and concludes relationships in a way that differentiates the boundaries between professional and personal relationships, that they communicate effectively and are respectful of a person's dignity, culture, values, beliefs and rights, that they recognize that people are the experts in the experience of their life. I really like that one. That they provide support and direct people to resources to optimize health-related decisions. That they advocate on behalf of people in a manner that respects the person's autonomy and legal capacity. That they use delegation, supervision, coordination, consultation and referrals in professional relationships to achieve improved health outcomes. That they actively foster a culture of safety and learning that includes engaging with health professionals and others to share knowledge and practice that supports person-centered care, that they participate in and or lead collaborative practice, and that they report notifiable conduct of health professionals, health workers and others. Now, I don't think there's anything in those criteria that you won't recognise, particularly given the fact that those criteria are based on the consultations that occurred last year and the year before with the nursing, well, in this case, the nursing profession, in order to actually redesign those RN standards for practice. And you will have been taught about these criteria in your undergraduate education, and I'm sure you will have discussed the issues, even if without reference to the national standards in your clinical roles. And certainly each year when you complete your renewal document, you affirm that you believe you meet these standards relevant to your context of practice as a result of compliance with your CPD. And your Code of Professional Conduct, which sets the minimum standards for practice in Australia, expects that you meet the criteria in these standards. So what I'm going to do for the rest of this talk is actually to cherry pick the criteria and briefly discuss some of the best, that should be bits. I spotted that on the way up. I've decided it must think that I'm a New Zealander, the best butts that I've read or seen about the issues. Okay, so I wanted to start off with this notion of professional boundaries. And this work, of course, has been around for ages, and it talks about the zones of practice, and it talks about zones of under-involvement, which are behaviours that lead to and include neglect and assault, zones of helpfulness as being the ideal relationship that we have, and zones of over-involvement, which refer to caring about rather than caring for our patients. And that work was actually adopted by the NMBA in 2010. It was around long before that, but it's currently under review with the codes of conduct. And in fact, we're looking to include issues around professional boundaries into the codes, as far as I understand. So the zone of helpfulness talks about safe practice and safe and therapeutic care, and this clear distinction between professional and personal relationships. I want to spend a little bit of time on that in relation to this notion of generosity, because I want to pick it up again later. So if you look at the zone of over-involvement, the nurses' behaviours, they say, are risky and exploitative, but how the patient perceives them is that they are intrusive and abusive, and of course they are illegal. If you look at under-involvement, well, the nurse behaviours are risky, but on this occasion abusive rather than intrusive, and the client perceives those as insensitive and neglectful. And one of the things that I say about nursing often is that when we nurse really well, then we are eminently forgettable. People actually don't notice what we do if we do it well. If we do it badly, people say, you know, the nurse was rude, the nurse was abusive, the nurse had rough hands, these sorts of things. So when we are under-involved, then actually people talk about this insensitivity or this neglect. So how do we know that we're crossing a boundary? Well, there may be a presence of favoritism if we're over-involved, or minimal care or neglect if we're under-involved. There may be judgmental attitudes, there might be burnout or cynicism, there may be some level of codependence, some possessive or secretive behaviours, rudeness or patronising behaviours, roughness or bullying or assault. There might be an absence of sensitivity or individualised assessment of care, or listening or taking time, presence or being there, concern, noticing, accountability, understanding, and putting ourselves into others' shoes and being aware of the client's rights. And this question of effective communication, which again I'll come back to in a little while. So this is some of the work that was done by that group who actually looked at boundaries in the early stages. And in terms of cherry picking, I think this is brilliant. I've used this all over the place, so I'm sharing it with you. Do you ever view your clinical role as meeting all patients' needs? Are you in an emotional crisis because of a divorce or the breakup of a significant relationship? Are you emotionally unfulfilled or over-involved with your work? Have you ever spent more time than is clinically necessary with a patient? Treated a certain patient differently than others when not clinically indicated? Made plans to see a patient when not on duty? Come in early or stayed on duty later than you needed to? Did you ever dress for work with a particular patient in mind? feel that others misunderstood a patient and were too critical or jealous of your relationship or rapport, make or keep secrets with the patient, consider a certain patient to be yours and made arrangements to be a primary caregiver, and behave in a guarded or defensive way when questioned about your interactions or relationships with the patient. Okay, I'm going to move on to the second one now, which is about communicating effectively and being respectful of a patient's dignity, culture, values, beliefs, and rights. It is long known that communication failures are the most common cause of SAC1 events. And so I'm not going to actually talk too much about communication in relation to generosity, but I do want to talk about generosity and respect, particularly in this time of unfortunate xenophobia and a global move towards increasing nationalistic sentiments. Because we are very fortunate as nurses to know more about people than most other players on the stage of life. And we know that there is good and bad in everybody, regardless of skin color, culture, values, and beliefs. And we know that ordinary people are capable of greatness and that great people are capable of ordinariness. We see the joy at a new birth and the sorrow at a death. And we know that these are no respecter of status, age, culture, or ethnicity. And this is one of my favorite poems by James Shirley, which is called Death the Leveler. I'm not going to read the whole thing to you, you'll be glad to know. But the glories of our blood and state are shadows, not substantial things. There is no armor against fate. Death lays his icy hand on kings. Scepter and crown must tumble down, and in the dust be equal made with the poor crooked scythe and spade. So I'm sometimes asked, well, don't I have a right to my own values and beliefs? If this is the case, so don't I have a right to be xenophobic or nationalistic? And my answer is similar to the response in relation to boundaries. Yes, if you feel you must, you do have a right to your views in your personal relationships, away from work, but never in your therapeutic or professional relationships. Your professional relationships are paid, time-limited, and structured. There are unequal power differentials and greater responsibilities on your part as the professional. And they require preparation, orientation, and training. They exist within a contractual arrangement. And in these situations, we expect that you will engage and facilitate patient growth. We expect you to be non-judgmental and to demonstrate empathy, acceptance, genuineness, respect, rapport, and caring. That is what generosity is about. And my view is that if you can't do those things, then you need to get out, at least until you can again. So I'm going to skip some of these criteria as needing no further comment, even though I do love the notion of experts in the experience of their life. But these ones I'm not going to talk about tonight because I do want to move on to some of the ones that I think are really interesting in relation to generosity. And one of those is about advocating on behalf of people in a manner that respects the person's autonomy and legal capacity. Well, clearly this subject is a lecture all on its own. I could truly talk under wet concrete on this one, but I promise I won't. It is a highly fraught and contested space with bioethicists and lawyers, but it is taken as a given by many nurses. Because one of the reasons why it's a contested space is that advocacy by definition suggests an adversarial scenario. So against whom is the patient in conflict? That they are in need of the nurse as an advocate. Sadly, sometimes this may be the doctor, but if the next criterion works, then that shouldn't be the rule. It should only be the exception. And what if the patient needs an advocate against the nurse? Who will be the patient's advocate at handover when a nurse is giving vent about a difficult patient? And one of the studies that we've just recently done shows that in relation to autonomy and capacity, we are more likely to acknowledge a patient's autonomy and capacity if they're agreeing to treatment than if they're refusing it. We actually doubt their capacity and autonomy if they're refusing. Okay, let's have a look at this active fostering of safety and learning that includes engaging with health professionals and others. So that's that question of, well, if we're doing that and we're doing it well, should there actually be a need for an advocate? Or is it, in fact, that we can discuss this as an interdisciplinary issue together? And the elements of a hospital unit safety culture are widely acknowledged across a number of studies. And these are overall patient safety, frequently of events reported, including near misses, the unit manager or leader promoting safety, organizational learning, continuous improvement, teamwork within the units, communication openness, feedback on error reported, non-punitive responses to error, adequate staffing, hospital manager or leader promoting safety, teamwork across units, and quality of information handoffs and transitions of care. And all of these, of course, are consistent with the concept of collegial generosity and inconsistent with any form of bullying. And there's been a lot of work done, particularly in the medical profession recently, about bullying. And despite a widely held view that bullying is an industrial issue and needs to be managed at source through these channels, I am firmly of the view that bullying is also both a patient safety and a misconduct matter, and needs to be taken more seriously by the Nursing Midwifery Board of Australia, because I think that in the past it's not got to them. It's been seen as something which is actually industrial rather than a misconduct matter. So not that they didn't take it seriously, just that it's not something that has been a professional misconduct matter. Okay, I'm just really briefly going to talk about notifiable conduct because I know that it causes some confusion and concern for nurses and midwives, and it is one of the criteria for collegial generosity. So all registered health practitioners have a professional and ethical obligation to protect and promote public health and safe health care. And they have these mandatory reporting responsibilities under the national law. So education providers, registered health practitioners and their employers must tell AHPRA, the NMBA, the New South Wales Nurses and Midwifery Council, the Health Professionals Council's Authority, or the New South Wales Healthcare Complaints Commission, if they formed a reasonable belief that a registered health practitioner has behaved in a way that constitutes notifiable conduct, and that is defined under the Act as practicing whilst intoxicated by alcohol or drugs, sexual misconduct in the practice of the profession, placing the public at risk of substantial harm because of an impairment, a health issue, or placing the public at risk because of a significant departure from accepted professional standards. And the threshold is this notion of the reasonable belief. So in other words, we can't just think that there might be a problem, we have to have a reasonable belief. And that belief has to be based on reasonable grounds. So in other words, we're going to have to find evidence. But if you are a registered health practitioner, employer or education provider and you're not sure, then you can contact AHPRA or indeed one of the other organisations to discuss your obligations in a confidential way. So if these are the criteria that the profession has identified and the NMBA has published as relating to collegial generosity, then how do we help ourselves to behave in that way? Well, my view is that we need to do four things. We need to develop resilience, we need to exercise, we need to develop mindfulness and kindness. And I want to talk about each of those in turn before I hand over to you to ask me questions. So resilience is most appropriately conceptualized as a developmental process or a dynamic capacity, rather than as some sort of static outcome or trait. And in the context of applied science, it also carries a connotation of some positive or typical developmental adaptations despite exposure to clear threat of adversity. So this notion that you can't actually be resilient unless something tough is going on. You can't sort of develop resilience in a vacuum. There's got to be stuff to make you resilient. Well, I think probably nursing and midwifery has lots of stuff that we get involved with that makes us resilient. So I don't think that's difficult. It's applicable to a broad range of systems ranging from children and families to institutions and societies. And it encompasses this capacity of a dynamic system to adapt successfully to disturbances that threaten system function, viability, or development. So how do we develop resilience? Look, I just want to briefly talk about this. This was actually in the Australian College of Midwifery journal this month. And it's written by a student midwife, and I actually think it's lovely. So I'm sharing it with you because I could give you all sorts of homilies, but I thought this student midwife nailed it for me. B, she says, pick your battles and breathe. E, exclude no one. You may be surprised who can help and what you might receive in return. K, know your strengths. When they are needed, you will know what they are. And this is Chiarella in italics here. And if you know someone else has the strength in something you don't, include them if appropriate. Imagine you are worthy. You are enough. Negative thinking is not your friend. Try a 28-day no news is good news challenge. And D, do something for someone else without any expectation of anything in return. And that was Ms. Burnshaw. I'm afraid I've lost her Christian name, but she was just great. I thought that was a fabulous little paper. Okay, let's have a look at exercise. This might seem an odd thing to put in here, but actually there's so much evidence about it at the moment that I thought in terms of actually feeling good and feeling generous. So it shows that physical activity seems to be an important factor that can have beneficial effects for all sorts of wonderful long-term diseases, and of course we are an aging profession. And so these, I'm not going to go into the details of the systematic review, you'll have it yourselves after this, but basically it looks at a whole range of things, and it also looks at our physical activity in relation to improving our psychological benefits. And another systematic review of exercise on anxiety demonstrated that it's also effective as an adjunctive treatment for anxiety disorders, and that's both aerobic and non-aerobic exercise. And I think that in terms of developing the resilience, I think you have to think, okay, so we know that we need to be resilient in order to be generous. So exercise is something that can help us to do so. Mindfulness. Mindfulness is defined as the capacity to intentionally be in the present moment without judgment. And again, there are systematic reviews on all of these things nowadays to show how well they work. And a systematic review on the impact of mindfulness and anxiety and habitual worrying demonstrates that there are beneficial effects for stress, depression, and anxiety, all of which come out of those challenges that we were talking about before. And there are literally hundreds of websites teaching basic mindfulness activities. But this is from the Selene Institute, and I quite liked it. Many people get interested in mindfulness as a way to deal with stress or difficult situations. This is a great idea. However, trying to be mindful for the first time in the middle of the crisis is a lot like trying to score the game-winning goal when you've never gone to a single practice. Don't make it harder for yourself. Start with pleasant moments, and you'll be ready to deal with life's challenges when they come your way. And finally, I want to talk about kindness, and this is one of my favorite quotes. If you have to choose between being kind and being right, choose being kind, and you will always be right. And this is just from a website, on an essay on a website. It is not appropriate to try and measure kindness. It is far too large and pervasive a thing in the lives of people to be pinned down on some sort of pseudo-numerical scale of 1 to kind. The significance of an act of kindness is subjective rather than objective. It might mean nothing to one person while profoundly affecting another. Following logically on from this, in finding no scale on which to judge kindness, we should perhaps view any one act of kindness as being able to stand alongside any other in terms of importance. Each kind act is simply an act of humanity and is as valid as any other in terms of its contribution to fellow creatures and the world that we live in. In our ability to be kind, we are all equal. So although kindness can never be given a concrete and tangible value, this in no way means that kindness is without value. In fact, it is viewed as quite invaluable. And it is necessary to us, so much so that Goethe describes kindness as the golden chain by which society is bound together. And kindness within a society is essential and absolutely necessary in order for humans to coexist and live even relatively harmoniously in such large groups. More so, it is safe to presume that the more kindness exists in any society, the more harmony there is likely to be. And it seems to me that this concept of kindness brings this notion of collegial generosity full circle. Because basically, if we can manage to bring to those criteria that we discussed from the registered nurse standards, the acts of mindfulness, resilience, exercise, and kindness, then I am content, mindfully, to leave this with you. Thank you.
Thank you, Mary. That was a fantastic presentation, very thought-provoking, and we're waiting for some questions to come through. So I'll remind everybody, if you have any questions for Mary, all you need to do is to type your question on the right-hand, on the tab on the right-hand side of your screen, so it should be coming up for you. But I've got some to kick off while we're waiting for questions. I think that your point about mutual trust and respect is a really, really important one. Got any really ideas for concrete suggestions of what we can do in our daily working lives to do simple things that will build mutual trust and respect between not only nurses and midwives, but other health professionals?
Sure. I think one of the things that we are quite lucky about in nursing is that in most scenarios, we travel in packs, if you like. There are several of us around. And I think that we can get into the habits, particularly through using work as a learning environment, of actually teaching each other. So I think that one of the things that we can get into the habit of, and certainly some of the work that came out of the models of care work, was actually, if you are working in a team, then rather than imagining that you have your own group of patients that you are totally responsible for, and if you don't manage your care, then there's something wrong with you, you can actually say, okay, so I need you to tell me about this because I don't know. Yeah. Or I know about this, can I share it with you? So I think that really simple, generous acts of knowledge sharing, or generous acts of saying, I don't know about this, but I think you might.
Can you help me?
And can you help me? Are really basic, simple things that we can do. And certainly one of the things we know from some of the work that some of my doctoral students have done, particularly a chap called Greg Fairbrother has published on this, is actually that when people are working in patient allocation, they feel very nervous about admitting that they don't know, that they have to carry their own work. And certainly if you have teaming, it helps to support people. That's not to say that we shouldn't have our own patients. It just simply means that what we have to be able to do is feel that we're supported by others around us with our patient load.
So that stresses the interrelationship between competence and confidence, doesn't it?
Absolutely.
And that's something that we need to actively work on and reflect upon.
Indeed. And one of the things that we know is that actually being competent is about knowing what you can do, but also knowing what you can't do. And some of the work that we've been doing in some research that we're just about to publish on actually is the understanding of insight. And we're actually just about to publish some work that we've been doing with Nursing Midwifery Council of New South Wales, looking at the elements of insight. And what we know about the elements of insight is that it is actually about recognizing when you are competent and recognizing when you're not. And we don't think there's anything wrong in recognizing that you're not competent. We think it's actually a really healthy thing, because then you can ask someone who you believe is competent to assist you. Does that answer your question?
Absolutely, it does. Before our session this afternoon, Mary, we were having a bit of a chat about power and the relationship that nurses and midwives have to the concept of power. Do you think that collegial generosity and being very good at practicing that will contribute to building power?
I think that if we feel that we're supported, then we feel that we are more powerful. And you don't have to be supported from above. You need to be supported by your peers, because clearly revolution started because people were supported by their peers, not because they were supported from above. But I also think, and this is what we were talking about earlier, Beth, that there is this real risk that we've been so good at making do in nursing. We are the best Band-Aid people. We're the best scrimpers and savers, you know, and this notion that we might actually be profligate or that we might be a cost is so wrong. I mean, we are the people who save money constantly in an organisation. And sometimes I don't necessarily think that that helps us, because I think there are times when we need to develop a sense of entitlement, not for ourselves, but for our patient care. And I think that if we can develop that,
yes,
and actually share that through collegial generosity, then actually we will develop a stronger sense of power. What we tend to do is people say, well, can't you just cope? Oh, yes, all right, I can fix that. You know, we're such good fixers. I say, I think it must have come back from the time when we were, you know, working in religious houses or something, and, you know, darning our lace.
Yeah.
I don't know what we were doing, but...
And we see ourselves as the problem more often than not. So we problematize ourselves
That's
rather than
right.
looking more broadly.
Yes,
Yeah.
I agree.
Yeah. I've got a comment here from Diane, who says, I'm a supporter of this framework in professional and personal life. As a nurse executive, I've commenced twice daily snapshots with team leaders to encourage cross-pollination. Thanks so much for your words of wisdom.
Oh, thank you,
that's feedback
Diane.
from Diane. So that's something that Diane's doing in her daily life to make a difference.
That's fantastic. And I mean, interestingly, I think, just going back to the question of mindfulness as well, I think that ability to be in the moment, especially when you're at work, is such a critical thing, because often when we all come to work with a whole load of stuff, every single one of us, and sometimes work's really good because it just takes away anything else, and all you can think about is what you're doing right in that moment. And I remember reading years and years ago, when I had small kids, there was a study about burnout that showed that married women with children were the least likely to be burnt out, because actually you walk out of the house, leave the kids, and you start thinking about work. You walk out of work and start thinking about, you know, what you need to do for the kids. So I need to bake a cake for tomorrow, or make the outfit for school, or, you know, whatever. So we don't have chance in that respect to dwell on the things that might bother someone who went home to an empty house and played over the same tapes over and over again about what someone had said at work. But the flip side of that is, I think that sometimes when we're at work, we're not in that moment. We are actually thinking about a million other jobs that we have to do, and that takes us away from being with the patient in that moment. And so I think there's a whole range of mindfulness that we can do in relation to that that is helpful for people at work.
And as you said in your presentation, that takes practice. Doesn't just happen.
It certainly doesn't just happen.
And I have to allow the time to do that.
Yeah. Look, I mean, I've recently started to learn how to meditate, and my teacher said that I've got a monkey brain, because apparently it jumps all over the place, you know. And I think nurses probably get really good monkey brains. And so, yeah, learning to be mindful, I think, is a really helpful thing to do.
Well, and I've just a reminder, everyone, to type your questions in or comments if you've got any for Mary. I've got another question, Mary, about your comment about nurses and midwives as advocates, and whether there's a need for that sort of frame, versus maybe the concept of a navigator. I think probably what often patients and residents need is someone to help them navigate the system rather than advocate for them. But I just want you to comment on, in healthcare, not only nurses, midwives, but doctors and other health professionals are the holders of specialist knowledge.
Indeed.
So there's a power imbalance there that we have to acknowledge that's central in the healthcare system. So do you think that we could situate advocacy in that context, in an acknowledgement, if we freely acknowledge that we have specialist knowledge that patients may not have? Is that less problematic?
I think it is, but I like your idea of the navigator. I don't know if you know Susan Sondheim's quote. That it's one of my favourite quotes. She says, "Illness is the night side of life, a more onerous citizenship. Each of us who is born holds dual citizenship, in the kingdom of the well and the kingdom of the sick." So if you think that nurses actually live with their patients in the kingdom of the sick a lot of the time, then actually that notion of being a tour guide or a navigator actually works really well, because just like your tour guide when you go on your trip, you know, there's someone there who's got like specialist knowledge. They can tell you what to buy at the local markets. They can tell you about the historical site. Look, I'm waving my hands. I can see them up there. Sorry, I should keep my hands down. But basically, it's that whole notion of specialist knowledge, I think, sits for me more comfortably with the navigator, the tour guide, than it does with the advocate. And interestingly, I was speaking at a law seminar last week, and one of the senior counsel there stood up and said, and by the way, the study was actually a study looking at nurses, doctors, and health services managers in relation to their attitudes to codes of conduct. And one of the things that all the nurses in the study said, I was commenting on the study, so it wasn't my study. All the nurses said, we are patient advocates. And one of the senior counsel stood up and said, well, you're not really advocates. You're not really advocates, because advocates are people who engage in this adversarial system. And for him, it was a really problematic concept that we would be advocating, because he said, you know, as I asked him my question, who are you fighting? Who are you standing up against? You know, and of course there are times, I mean, you think of Patel, you know, of course there are times when nurses need to advocate for their patients, of course. And I'm not saying that there aren't. But heaven forbid that that would be the way we live our daily lives.
As the norm.
As the norm, yeah. Whereas, hopefully, as a navigator, Beth, to pick up your term, we would do that every day and use that specialist knowledge.
In partnership.
In partnership, yeah. Or even where you might have, you know, someone who's not so knowledgeable, like, you know, me going through certain countries where I don't speak the language and what have you. You know, certainly your tour guide becomes someone that you lean on very hard. And that's fine.
Yeah.
You know, it may not be a partnership. You may be hanging on to the coattails, but if that's what you need to do, that's fine. But you're still navigating with them.
Yeah, absolutely.
And I think that's particularly when nowadays we talk so much more. And I do think power has shifted away from a medically dominant system to a much more patient-centric system. You know, and we do talk about patient-centered care. Doctors talk about patient-centered care too. You know, and indeed, if you read strategic plans for health, you know, LHDs, they talk about patient-centered care. So there is a shift to sort of give, if you like, power to the patient. But as you rightly say, they can't have the power if they don't know. So someone's got to give them the information in a way that they understand, that is digestible, that's, you know, comprehensible, and also probably in digestible chunks.
Yeah, and because nurses and midwives are there 24/7 with the patient, we've got an integral role to play in terms of
we are the perfect person to do that, yeah. But it is just, I mean, personally, I think the notion of advocacy is necessary, sadly, sometimes, but not desirable regularly.
It shouldn't be the
norm. No, that's my personal view.
Yeah.
But, you know, I think that I'd much prefer your navigator. I've used the term tour guide on, you know, a number of occasions. And I much prefer that notion.
Yeah. So we've got a comment or a question from Emma here.
Hi, Emma.
Wouldn't it be great to have mindfulness workshops provided by employers?
It would be great, but I don't think it's the answer. I think this is about personal responsibility. I don't see why we can't take mindfulness as our responsibility as health professions. That's not to say that employers shouldn't do them. But again, that comes back to me to that abrogation zone, whereby you say, well, we want someone else to provide this, rather than us taking that on as something that we do for our own wellness and our own well-being. And as I say, truly, duly, Emma, was it?
Emma.
Truly, duly, Emma, there are so many websites. You have no idea. I was seriously cherry-picking when I was looking for something. So I think, you know, it would be lovely to have them put on by our employers, of course, but that doesn't mean that we can't do it for ourselves, and should, just to be good to ourselves, generous to ourselves.
And can I say that's something that some of our branches have been doing? We just had a fantastic workshop that was arranged by midwives from Royal Brisbane and Women's Hospital along these sorts of issues about keeping midwives well, and really not only about diet, about relaxation, mindfulness. And that was a very, very popular session that people came down from all around Southeast Queensland to attend that. And that was something that was generated by one of our members who said we need to do this. They identified identified the need, and we facilitated that happening.
I'm firmly of the belief that this is about, I think, you know, we have to be good to ourselves in order for us to be good to anybody else.
And we have to think that we deserve it.
We have to believe that we deserve it. I totally agree. That's what that fabulous little student midwife said. Well, she might not be little,
yeah,
but you know, that fabulous student midwife said. I really loved her work.
So don't forget, you can type in some more questions. We've still got a few more minutes. I've got another one, though, about the dichotomy, which I think is a false dichotomy between industrial and professional. And I remember when I first started at the union, I always thought that it was a very strange concept to draw that boundary. I just didn't think that it exists, but I'm firmly of the view that it is absolutely a false distinction. And I'd like to get your views on what you think about that particular topic.
These are my personal views.
Mm-hmm.
I agree with you entirely. I think that of course, there are elements of your work that is completely industrial.
Yep.
But in my view, being a professional is also about being properly remunerated, being properly recognised, having proper working conditions, workloads,
mm-hmm.
all those sorts of things. So I don't see that those things are not also professional. I think someone has to do that work, and that work for some bizarre reason is seen as being industrial because it's collective bargaining, you know. But in my view, that work is actually about recognising the value of professionals as well.
And that probably gets back to our discussion we're having earlier about our sense of self-worth too, and
Yeah.
that we are worth it.
That's right. And
to be properly remunerated.
Yeah, of course. I mean, and the what I think one of I think one of the issues that for me is that I've lost my train of thought now. I'm so sorry. One of the issues about self-worth is that we basically need to recognise that the work we do is so important. And one of the things that has often happened in industrial issues is that we're always showing what else we're doing. And yet, often, in my view, the work that we do that is called basic nursing care has never been valued enough. And so if you were looking at a work value case for me, you'd have to turn the whole thing on its head, you know, because fundamentally, the work that should have so much value is the work that has always been a given for nursing.
Now we've got a fair few questions here. Now they come in really thick and fast at the end, so I hope everyone can hear me. I walked over to the computer to read them. This one is from Hannah. As a trained mindfulness and meditation facilitator and practitioner, I have in many of the positions I've held endeavoured to introduce this into the workplaces where I've worked. I've also presented at conferences and in-service education on this topic and how it works for us as nurses. I wrote a wellbeing program for one workplace in the hope that we can introduce and utilise this for our staff. Look after our staff, they will look after our patients better. Although I'm grateful to see this is finally inching its way into healthcare, where in the corporate world it is a far more widely accepted and implemented. However, I truly believe this is a much underutilised benefit. At present, I'm a nurse educator delivering the diploma to enrolled nurses. None of this is covered in their course. It's not written and it should be. I do, however, find every opportunity to introduce it and to utilise it as often as I can.
Well, fantastic, Hannah.
Hannah?
That is great, and I totally agree with you. I think we have to be careful about curricula because I think they end up being fuller and fuller and fuller. And my view is that this is actually part of that whole collegial generosity issue that comes into the standards. Now, I don't know if it's in the enrolled nurse standards, and I note that you're teaching an enrolled nurse program, but I do think that questions or issues such as mindfulness are actually about how we develop ourselves to be able to deliver on the standards. Yeah. But I totally, totally agree with you. It's incredibly important.
And here's a comment from Katie. Dear Professor Chiarella, thank you very much for your presentation. As always, you are a delight to listen to. In relation to your webinar today, I think as nurses we sometimes get so busy in not only our daily work but in our private lives, we forget collegial generosity is so important for us all. That's a comment from Katie.
Thanks, Katie.
Carolyn has a question. Has there been any research done on the relationship between workloads or nurse-to-patient ratios and collegial generosity?
I'm sure there hasn't, but I do know that there's been plenty of work done on ratios, workloads and stress. And I think that actually being able to deal with stress is actually critical. And we know that our workloads if they're excessive, that they cause us stress. But I think the flip side of that is that we need to think of ways that we can care for ourselves.
Yeah, absolutely. And here's a comment from Tammy. Thank you for your comment about that bullying should be treated as professional conduct. I am disgusted that bullying is still so rife and often excused or covered up by others, especially management. There is still a strong culture of bullying that needs to be stomped out. The nurturers need to nurture each other, not destroy each other. Yes, collegial generosity in action. Thank you.
Tammy, I quite agree with you. The one thing I would say is that it seems to me, and certainly if you look at some of the work that's been done around the medical colleges recently, that it's rife. It's not just rife in nursing, and I think that's a really important thing to be aware of, that certainly there's been a whole load of work done with the medical colleges. I've been really interested listening to some of the work that's been done in law firms. You know, I think that it was just a way that people were in the world, and we as a profession of nurturers have to be able to say enough, not having it, not doing it.
And to have the skills to do that, I think, is an important thing. To have the confidence to do that.
To have the confidence to do it, and to feel secure in the fact that we do know what we value. As I say, we've got 30 years of research on what nurses value, and the fact that regardless of what may divide us, there is far, far more shared value sets in nursing that unite us. And I think you're right. I think every now and again we just have to look up and remember, all of us.
That's the end of our questions. I don't think that we have any more. Are there any final comments that you would like to make, Mary?
Not at all, except I'm so pleased that some of you came in and commented. Thank you so much.
I would just like to say a very, very big thank you to Mary. It is always such a delight to listen to you. Every time I learn so much from your presentation. We have so much to learn as nurses and midwives from each other, and just practicing, as you say, kindness is a very important thing to do each day. So thank you very much. I know that all of the members will be online, and those will be able to view this online through the webinar that's going to be recorded. I will be fantastically appreciative as well. So thank you very much, and thank you for flying up from Sydney to do this. Everybody, that's it for tonight. That's a wrap. We will be having our next toolkit talk on the third Tuesday of the month, so that'll be the third Tuesday in May. And so watch out for details. It'll be emailed out to everybody. Again, thank you very much for your participation, and please provide feedback to us on the poll. There is a poll that will be sent out. They've got it now. People are nodding to me saying you should have it now, so I'm getting instructions. So please make sure you complete the poll. We really are reliant upon feedback from you about whether this is working for you. I think the presentation tonight has just been exceptional, and you would have got so much out of that. But any ideas you've got for other topics as well, please make sure you provide those through to us. So thanks very much for your time tonight, and have a great evening. Good night.